All right, we're going to move from urine specimens to talk about blood specimens. And so our joint team for this discussion is Dr. Eric Beck from Aurora Advocate System in West Allis, and Jorn Bansberg, sorry, I can't get the words out today, and Jorn's over in Viroqua at Vernon Memorial. So Eric's going to start us out, and then we're going to have the case studies led by Jorn after that.
Okay, thanks, Aaron. C was next. I think I just got old. I can't read this. I got it. Well, in my mind, I just got old. Okay, thanks. So as Aaron mentioned, Jorn and I are going to talk to you today about blood specimens. I'm going to start it off more, I guess, kind of the background and general workflow, and then we'll let Jorn do some actual case studies after I do that part. So a little bit of background on sepsis, or this is our outline for today. We'll talk a little bit of background on sepsis. Then we'll kind of go through the ins and outs of the blood culture process, starting from collection and contamination, followed up with incubation, and then through gram staining, rapid identification, susceptibility testing, and what do you do with some of those discrepancies that you may see from rapid testing and traditional testing. We're going to talk about some relevant metrics that you may want to track within your laboratory, and then we'll get to some cases and unique situations. All right, so sepsis is a dysregulation of the immune system caused by infection. It's the leading cause of death in non-cardiac ICUs and can have a mortality rate as high as 60%. Obviously, 2008 is a little bit old, but the statistics from back then were 1.7 million admissions due to sepsis in the United States, and it could have annual costs exceeding $24 billion. So not only are there problems monetarily, but obviously mortality-wise as well. One of the most important things going on during sepsis is timely initiation of both empiric and then targeted therapy so that we can decrease the mortality rates in these patients. But again, we need to weigh that against overuse of antibiotics so that we're not having adverse host effects like acute kidney injury or C. diff. When Heather was putting up her slides on ciprofloxacin on every patient, all I thought was C. diff, and that would be an interesting stat. But and then obviously also we want to be aware of increasing rates of antibiotic resistance in the bacteria we're seeing. So
clicker on the page again, and then it will work probably because we dragged it over. Yeah, just click there once. Okay.
Thanks, good save. So obviously, something that we're probably all familiar with, regardless of our roles, either in infection prevention or in the laboratory, is skin antisepsis and how the appropriate use of skin antisepsis can decrease the risk of contamination. And it's important because it can lead to, some studies have shown that one contaminated culture can lead to the hospital to have additional costs of over $4,000 per contaminated culture. We do use rapid IDs in some of our labs to help identify these contaminants faster and potentially decrease the effect to the patients and to the cost on the hospital. Obviously, faster blood culture turnaround times yield better outcomes. Some studies have shown that mortality rates can increase by 8% for every hour a septic patient is not treated appropriately. And then one of the main things we're trying to do as laboratorians is help providers intervene wherever they can. And some of these steps include antibiotic escalation or de-escalation, and they can generally occur after we report a positive gram stain result, once we've identified a specific pathogen causing the infection, or upon completion of susceptibility testing. So as far as that goes, patients who are suspected for sepsis are often started on empiric broad range coverage. This may differ depending on your hospital, but our general approach within Advocate Health is patients are generally started on vancomycin and either piperacillin tazobactam or cefepime to cover gram negatives. And our provider's goal is to get them onto the most effective therapy as quickly as possible and get them off of those broad range coverages. So our lab can play a role by decreasing the time from collection to loading in the incubators. This will generally speed up the time with which we can report a result. Most microbiology guidelines indicate that bottles should be loaded in less than 2 to 4 hours. Also, we can help the providers by decreasing the time from collection to the time they're able to get the patient on appropriate therapy using rapid identification methods, prompt susceptibility testing information, and by having active antimicrobial stewardship committees. And then just a few obvious examples of ways that results that we report from the lab can have a direct impact on the patients are things like the rapid reporting of Staph aureus or MRSA. This can often lead to additional antibiotics being added, or potentially for the cases of Staph aureus, MSSA being de-escalated from vancomycin. The identification of VRE, or vancomycin-resistant enterococci, can lead to immediate therapy changes in some of these patients, being escalated to daptomycin or linezolid. And for the gram negatives, rapid identification of some of the resistance mechanisms that we're starting to see within Wisconsin and where I cover in Illinois as well, really heavy amount of resistance mechanisms. And organisms that are positive for extended spectrum beta-lactamases, those patients may be escalated to meropenem. Organisms that are positive for carbapenemases may be escalated even further to something like meropenem vaborbactam or ceftazidime avibactam. And conversely, organisms that are negative for both of these resistance markers or genes may be de-escalated to something like ceftriaxone. So this is kind of a hard presentation to do because there are so many different ways to do blood cultures, and I would be willing to bet none of our laboratories do anything exactly the same. But we're going to give it a shot, and I'm going to try and touch on just the different things that you can or can't do. I'm not going to necessarily tell you what the best way is, because what the best way for us may not be the best way for you. So some of the things we're going to talk about in the process includes the collection process, from who is collecting, what your skin prep looks like, do you use diversion devices, where do you incubate your blood cultures? Are they incubated in a centralized location? Do you still incubate them within your hospitals? If you're within a system, are you incubating them in a decentralized manner at each hospital? Where do you process your positive bottles? And do you use rapid identification methods? What does your definitive identification process look like? How often do you do a definitive ID? Do you do a definitive ID on everything? And same with susceptibility. Are you doing susceptibility testing on all of the isolates you identify within blood cultures? And then lastly, how can you use relevant metrics to understand your contamination rates and gram stain errors and things like that to drive better patient care as you go forward? So we're going to start with blood culture collection and specifically with who is collecting and why does it matter. There are studies that demonstrate trained phlebotomists have decreased contamination rates versus clinical staff. I don't know that I would have to really, I'm sure you all believe me on that one based on who's in this audience. And most of the differences tend to come in gaps in knowledge around the common causes of technique, right? Things that we're familiar with as laboratorians and how we do some of our skin antisepsis, right? And it's somewhat incumbent on us as laboratory staff to have good education and training programs to train the nursing staff and the clinical staff during collection of blood cultures. And it's been shown in studies that this will lead to significant reductions in blood culture contamination. As I said, in addition to having a training program in place, it's also important to have some kind of mechanism to follow up and re-educate, make sure the training programs are repetitive, and just really continue to Except once you see that, you've made an improvement, right? Don't just assume you're done. It will revert if you let it go, right? So in addition to who's collecting, we need to know what should they be collecting, right? The current culture recommendations include blood culture sets, 2 to 3 sets for a suspected bloodstream infection over 24 hours. I think there's some debate in terms of whether cultures should be collected simultaneously or over an interval. The current recommendation is that they can be collected simultaneously. I know in our system we have providers that insist on an interval, and we let them do it, but whatever makes them happy, I guess. But I don't know that we don't see any significant difference one way or the other. And generally we're looking for a paired aerobic and anaerobic bottle containing 10 mils of blood in each bottle. In terms of disinfection recommendations, the current recommendation is to cleanse the venipuncture site for 30 seconds with alcohol and then allow it to air dry, and then cleanse it with a second disinfectant like iodine or chlorhexidine, and allow that to stand for whatever the manufacturer's appropriate recommended dwell time is. And then once you've cleaned the site, don't palpitate the vein and unclean the site. I probably shouldn't say it, but I was having blood cultures drawn for myself for a study, and that was the very first thing they did after they did it. And I said, let's try again. I was supposed to be the example of a negative blood culture bottle, and so that was not really the way to start it. But obviously contaminated cultures can lead to increased costs, length of stay, and additional work for us in the lab. And so this is going to be kind of the first point. Probably laboratories have probably a similar definition of what a blood culture contaminant is, but generally what we would be thinking within our laboratory is a single bottle or a single set that's positive for bacteria that you would commonly find on your skin, like coag-negative staph, Cutibacterium acnes, Micrococcus, viridin strep, Corynebacteria, Aerococcus, that one's for Eric Munson back there, and Bacillus. So before I get into the next steps, I am going to ask you a question. Do you guys divert or discard blood when collecting blood cultures? If so, which diversion method do you use? A, the current jet, B, Magnolia Steripath devices, C, an extra vacutainer, D, we focus on skin disinfection, or E, what are you talking about in terms of diverting blood? What were there, about 50? All right. Okay, interesting. So the majority are just focusing on skin disinfection with, I guess, second place being use of a additional vacutainer. Go ahead, Jorn.
We've had great success with just using an original syringe to do regular chemistry and hematology testing, and then using the second and third syringe for the blood culture bottles, and that really lowered our rate of contamination immensely.
Very good. So for those of you that may have hit E, I think there was at least one in there. These are what some of the diversion devices look like. The one on the top is the current jet, and the two on the bottom are the different Steripath devices. Basically, the point of these devices is to take the initial blood that comes out of the vein, and including some of the potential skin that may be coming with it, and trap that and divert it away from, I guess, segregate it away from the rest of your specimen so that those initial bacteria won't end up in your blood culture bottles. There are plenty of studies showing that these do decrease contamination rates, but they're very expensive. And so I've seen upwards of $15 a piece for these. I don't know what that looks like in your labs or what rates you're getting, but for a system our size with 30 hospitals, $15 for every blood culture is a pretty large fee. Go ahead, Tyler.
Just to Jorn's point too, with the extra syringe or vacutainer. We also employ that. However, it's nursing staff that do all the collections. We have not seen significant drops related to it. So related to diversion devices, I think, it's a tool, it's not a silver bullet. I think is probably one of the biggest call-outs related to that too. So,
yeah, thanks, Tyler. This is a super busy slide, and I'm not going to read it to you, but it actually does kind of indicate what you just said, Tyler. Within our laboratory, we have had some hospitals, or I should say, within our hospital system, we've had some hospitals trial the SteriPath devices or the current jet, and initially, when they were being trained, basically their training consisted of really good skin antisepsis, right? This was what the team was being hammered on, right? And then they used the diversion device, and they all generally saw a significant decrease in their contamination rates initially. But then as time went on, and they got a little more lax potentially in their skin antisepsis, we saw those rates come back up, right? Tending to indicate that the diversion device wasn't so much what was solving the problem as their retraining on skin antisepsis was, right? And so I can tell you within our healthcare system, the sites that have the lowest contamination rates for blood cultures are actually sites that don't use those devices and focus really, really on training. It's also probably fair to say those sites have a lot more phlebotomy collections, but still, even their nursing staff in those sites are much lower than some of the other sites that use the diversion devices. I'm going to touch on what some of the techniques Jorn and his team use at Vernon Memorial. They have both physical and social strategies that they use to reduce contamination. They insist upon that two-step cleaning with alcohol and iodine or alcohol and chloroprep, as I indicated earlier. They also have people understand that if the initial alcohol wipe is dirty, start again, right? Start over, right? We want to make sure that surface is clean. That's the purpose of that wipe, the alcohol wipe, right? Before you do the disinfection. They focus on utilizing pressure during cleaning, and then ensuring that everyone is accountable for the drying time. So they want to, depending on whether they're using iodine or chloroprep, right? They want to make sure people understand that the drying time is important. Even if you're the one watching the blood culture collection, make sure you're helping understand that the dwell time is important, right? They also stress, don't palpitate the vein after you've cleaned it, right? And as Jorn mentioned, that they use the second and third syringes after IV starts. So they use that first syringe kind of as a void tube or a tube for their other tests, right? They also have an active social program used to monitor and verify the success, or they monitor and verify the success with their robust quality assurance and quality improvement program. They're monitoring rates both from the organization as a whole and from individuals. They have a retraining program if phlebotomy teams have more than 2 contaminated cultures per quarter. And they send out a PDSA email to nursing, plan, do, study, act emails to both nursing and phlebotomy staff drawing these blood cultures to basically point out what the contamination rates are, both for IV starts or venipunctures. They include technique reminders when the rates are high, and I think this one's important. They lavish praise on those teammates who have low contamination rates, right? Just to reinforce that you're doing a good job, you're doing the right things, keep it up, and I think that probably helps people refocus and remember what they're doing. And then they allow their teammates to use smaller syringes. The less cumbersome size of some of the smaller syringes may decrease their rates of contamination. So the next thing I'm going to jump into away from collection is blood culture incubation, right? And this is probably a little bit variable for everyone out there, but as hospitals and microbiology labs in general consolidate, they face decisions on which testing will remain on site. Blood cultures are probably a common one that they're debating about. Again, as you're making those decisions, whether you want to centralize your blood cultures or leave them on site, you want to keep in mind how you're going to be getting those blood culture bottles to your incubators. Again, You want to try to do that within 2 to 4 hours. So if you're centralizing, do you have to have a set of stat couriers or more frequent courier rates? Does that make it harder on your lab to do that? If you're decentralizing, obviously that requires a significant investment to have equipment at all of those sites, right? You also have to consider the skill level you have. As you consolidate, do you have folks left in the laboratories who can read gram stains? Whereas in a centralized area, you have a pretty good idea that your gram stains are going to be read by dedicated microbiologists. You might have a little bit higher accuracy when they're coming to the centralized area, right? And then if you're going to remain decentralized, do you have a rapid identification method on site, or do you just set yourself up for the same problem once your culture goes positive? Then you have to send it to a different lab or whatever. So all things you got to consider when you're figuring out whether you're going to centralize or decentralize blood cultures. Other things in terms of incubation, I would guess most of us are doing this pretty similarly. But generally, blood cultures should be incubated at 35 to 37 degrees. The current recommendation for automated blood culture systems is a 5-day incubation. This includes for slower growing things like brucella, Haysick organisms, nutritionally variant strep, even in terms of patients that are suspected of having endocarditis. So I don't know how often you guys may get phone calls from your provider saying, I suspect a Haysick organism, can you hold it for an extra whatever insert number here? I don't generally honor those unless I really get yelled at. But for the most part, we don't honor those, and we only hold them for 5 days. There are some studies showing that you might even be able to consider decreasing these incubation times to 4 or even 3 days. 3 days feels short to me, but I guess I could see where if your data supports it, 4 days may be a reasonable option as well. The next thing to consider is gram stains. Gram stains are something that I would expect you would be performing on every positive blood culture bottle relatively promptly. These can guide additional workup. For example, does your gram stain dictate that you want to do a rapid molecular test? Or which molecular test cartridge are you using, and depending on which system you use? It could dictate additional media or subculture collections. For example, if you see a gram stain that's indicative of Campylobacter or something, do you set up additional media or change the incubation conditions that you use? Potentially to a lesser extent, it may provide the providers with some therapeutic guidance, right? They at least know whether they're maybe suspecting a gram positive or gram negative. And lastly, it may have some infection prevention ramifications. For example, if you see something like a gram negative diplococci, that may indicate Neisseria meningitidis, and it may lead to additional isolation procedures for that patient, right? And then in an ode to Aaron for biosafety here, please process your gram stain bottles within a biosafety cabinet. The act of blood cultures going positive may often lead to gas buildup in some of these blood culture bottles and things like that. And as you stick your needle in to vent them, right, you can aerosolize bacteria and gas coming out of there, which if you're not doing it in the biosafety cabinet could lead to a dangerous outcome for the lab staff, right? And then also the gram stains and the time to positivity can help your laboratory decrease, or if you're paying attention, you can decrease your exposure risk within the laboratory, right? You can avoid potential exposures to your teammates. If you're paying attention to slow-growing gram-negative coccobacilli like Brucella, Francisella, if you're accounting for gram-negative diplococci like Neisseria meningitidis, and then keep in mind, how do you alert others, right? What if someone else is following you on this culture? How are they going to be aware as they pick it up that this may be more of a risky culture, right? This is an example of what we do within our lab at ACL. If we have something that's growing, like a gram-negative rod, for example, that's growing or took longer than 36 hours to grow positive, we tape up the plates and put a sticker on the back to let the next person who's working on it know that there may be something of higher risk there. and that they should proceed with working those cultures up in a biosafety cabinet. There's obviously nothing growing on that plate. That's my poor taping job, and they would do a much better job. So next we're going to get into rapid identification methods. And so just to poll the audience here, which rapid identification methods for blood cultures do you guys use? Do you, A, not use a rapid identification method? Do you use the MALDI in some capacity, either the sepsi-typer or slime or scum method? Do you use a targeted molecular test like a MRSA or MSSA test, a multiplex panel, a rapid identification AST system like Accelerate or the new BioMRU ViCheck Reveal system? Or F, do you use some other rapid method that I haven't hit on? There's no F button, but I would be curious if you raise your hand if there's something else you're doing. So go ahead. It doesn't appear that there's any Fs, so hopefully I've covered all the options. Okay, so most of us are using the rapid molecular panel with the greater than 5 targets. A few are not doing rapid identification. And there's a few using the other methods out there. So,
hey, Eric,
yeah.
I guess I could be an F. I just realized if our BCID...
Of course you would, Tom.
We'll do the scum.
So you do BCID or scum?
Well, if we set the scum up, if the BCID doesn't work, and then we'll do the scum if, you know, it's not something that BCID identifies. So we kind of leverage our MALDI.
So I'm gonna turn it around on you then, Tom. This is what you get for volunteering. How often do you get a positive result on your scum method that didn't get picked up on the BCID? What would that tend to be? Your bacilli, your gram-positive rods?
You're asking the wrong guy. It happens, you know. It'll be a different, you know, bacteriales or, you know, it happens. Yeah.
Sure.
It happens enough to keep doing it.
Okay. Yeah. I guess I would have, for us, I think when we were I'll get into it a little bit, but when we were doing the slime or the scum method, we didn't have great success with some of the gram-positive rods and the slower growing things we didn't really try. And those would tend to be the things we wouldn't pick up on the BCID. So following it up with the MALDI for us wouldn't have totally helped us. I think it all depends, right? I'm just trying to figure out whether or how what you would get. Go ahead.
Sorry, I don't know what you mean by slime method.
So basically, when we're doing a MALDI plate, you can put like a drop or two of your positive blood culture media plus blood onto a blood auger plate and incubate it for a short amount of time, like 5 hours, and then you get growth on that plate, kind of in a little circle where you put that drop right. And it's not really isolated colonies; it's just kind of slime or scummy growth, right? And you just do set up your MALDI from that. Is that? So I lucked out that you guys all picked rapid molecular tests. So which rapid molecular panels are you guys using in your lab? Do you use the BioFire test, the Verigene system, the ePlex, a different molecular panel, or for those of you, I guess, that aren't using molecular panels, can hit letter E? BioFire and Verigene seem to be the winners. Okay, so then many of you will recognize a lot of this, but obviously there's several different types of molecular panels, right? There's the comprehensive panel like the BioFire where pretty much everything's on the same panel. There's some of these smaller panels like the ePlex or the Verigene system where they're broken down potentially by morphology, so gram positives or gram negatives. Then there's an even more directed tests like the Cepheid MRSA, MSSA test where we're just looking for Staph aureus and MRSA. Most of these are rapid at less than an hour, maybe 2 hours. I don't know where the Verigene shakes out these days. 2 hours maybe, does that sound right? Okay, thanks. Okay. So I still have a little bit of residual Verigene knowledge in my brain. Most of these molecular panels include some type of antibiotic resistance markers, but they do obviously require specialized equipment. They can be expensive, both the tests and the instrumentation. And we found, at least for the BioFire test, that we identified the offending pathogen in greater than 80% of our positive blood cultures. It leads to these panels, while they're great, right, and they have a long list of organisms that they can identify, it does lead to issues in terms of how you're reporting it, right? Are you line listing all of the results that you could? Are you only reporting the positive targets? If so, how do you know what targets were negative? How do your providers know that, right? Are you always reporting antibiotic resistance markers out, even if the test was negative? Or do you provide any kind of result interpretations for your providers, right? So this is a copy of the BioFire printout for the BCID2 test, right? It's obviously pretty long and unwieldy, and it's kind of hard to put into a patient report. As an example, for a MRSA from the BCID2 test, it yields 3 positive targets, one for the generic Staph species, one that's positive for Staph aureus, and one that's positive for the methicillin resistance mechanisms. Do you actually report all 3 of those targets out on your patients? If you do you get calls from your providers that say, well, you reported Staph species and Staph aureus. Do I have 2 different pathogens here? Do I have a contaminant and a pathogen? Do they just understand it? I can tell you our providers did not when we did it that way. It did not go well. So I'll show you briefly what we do, but this is I mean, you obviously can't read it, but for the same example at ACL, in our laboratory system within Beaker, we do have all of the targets built. So there is the target for the Staph species, the target for Staph aureus, and the target for methicillin resistance. All the results do go across our interface, but then on our final actual patient report, we only report one thing. In the case of the previous one, the only target that actually gets reported is the Staph aureus target. The Staph species and the MECA genes are hidden. And instead of just reporting detected or not detected, we have an interpretation that basically says this is a methicillin-resistant Staph aureus. We found when we were doing it the other way, or we were reporting more, it was just leading to too much confusion. And so this is how we do it. But we do report the bulk of the other things in a big list, and we certainly get complaints about that as well. So it's clearly not a perfect method. So getting into other rapid identification methods, right? The MALDI-TOF, as Tom indicated that they're still using it, is one. This can identify a lot more organisms in positive blood cultures. It's also requires generally expensive instruments, but the testing is a lot cheaper. There's a couple different ways you could do rapid MALDI. That would include the sepsi typer on the Bruker instruments, which is basically a processing approach that allows you to go directly from that positive blood sample, and takes about 15 to 20 minutes. Or as we were talking about, the rapid kind of slime or scum method, where you're putting a few drops of blood onto the plate. Sorry, a few drops of the positive blood culture onto the plate, and then incubating it for a few hours and performing MALDI. As we saw, this tends to work better for gram negatives. They're a little bit faster growing, and we tend to get a little bit better result. So we did used to do the rapid slime or scum method prior to 2022 within our lab. Again, it was cheap. It was relatively fast, took about 6 hours after the bottles went positive. And we were seeing accuracy rates of upwards of 75%, particularly for gram-negative rods. But we didn't get susceptibility information. And within our hospital system, Advocate Health ranges all the way up from Green Bay down to Chicago. And particularly in the Chicago area, we see lots of high levels of gram-negative resistance, both with ESBLs and carbapenemase producers. And we found that our providers, even if they were getting that rapid identification, it wasn't enough for them to actually act without susceptibility information. So they weren't changing their therapy until they got the full susceptibility result. And for things like E. coli, Kleb pneumo, and Kleb oxytoca, what we found was the average time from collection to susceptibility results was about 58 hours. Even though they had that identification about halfway through that process, it still wasn't really causing them to make any changes until about that 58 to 60 hour mark. In 2022, we switched to the use of the BioFire BCID2 test. We found that about 25% of our cultures are positive for E. coli, Kleb pneumo, and Kleb oxytoca, as I had just talked about. And we went back and looked at 1 year of data, so 2,900 isolates for these organisms. And the BCID2 test predicted the presence or the absence of ESBLs or carbapenemase producers in around 99% of the cases. And de-escalation based on this result would have only led to ineffective therapy in less than 0.6% of the cases, right? So seeing this, our providers have now felt more confident that when they get that rapid ID and the susceptibility results that go along with the gram negatives from the BioFire test, that they can start to make some de-escalation or escalation decisions. So now they are taking action based on that BioFire BCID2 result. And what we've seen for E. coli, Kleb pneumo, and Kleb oxy is that the time from collection to the time we're reporting that BCID2 result out averages about 30.7 hours. So they've decreased the time, or we've decreased the time that they can take action by about 50%. So this has been a huge benefit for us, right? Obviously, it added cost to our laboratory and probably some complaints from our teammates and all that kind of stuff on what we're going to repeat and everything, but it did have a significant benefit for our patients and our providers. Next, we're going to talk about traditional identification. So this one's pretty wordy, but out of curiosity, how do you guys report identify and report organisms from positive blood cultures? Do you provide a species level identification of all isolates, or at least attempt to? Do you fully identify all pathogens and just provide a genus level or a minimal ID for skin flora bugs, regardless of the number of bottles they're found in? Do you fully identify all pathogens and do a genus level ID for skin flora bugs if they're only in one set, but then you fully identify them if they're in multiple sets? Or is your policy so hard to follow you can't even tell? There's going to probably be at least 4 picking D. All right, looks like we're getting close. So it seems like we're mostly in the range of fully identifying all pathogens and a genus level ID if you're finding a regular skin flora bug in one set, but you're fully identifying it if it's found in multiple sets. Followed in second place by people identifying all isolates fully every time. I'm not going to talk too much about this. You guys are probably pretty familiar with the traditional identification methods that are out there. Probably most of you are using a traditional MALDI-TOF method, which requires overnight subculture. It's obviously got a large database. The testing itself is fairly cheap, but again, you get no susceptibility information. Some of you may still be using biochemical methods like Vitec or Microscan, BD Phoenix. I doubt anyone's using API strips as your primary method, but I'll put it up there because it's fun. These do tend to have larger databases than our rapid molecular tests, but smaller databases than our MALDIs. And they may take, depending on which method you're using, up to 24 hours to get results. And again, no susceptibility information is provided. So as I touched on, when is a traditional identification required, right? Are you doing it on all positive bottles? Are you doing it on the first positive bottle in each set and then doing a minimal confirmatory ID on the second bottle? Do you do it once every few days if you have blood cultures that are going positive over multiple sets? Do you do it at all if you got a positive rapid molecular ID that said E. coli and you're growing a gram negative? Do you do a full identification? At ACL, we do a formal ID on the first bottle that is positive from any blood culture sets, that should say. And we will do the full ID even if the morphology matches the rapid test. Whereas for subsequent positive bottles in the set, we do a minimal ID. So again, others may have different approaches as far as that goes, and certainly would love to hear it. Briefly going to talk about susceptibility testing and which organisms are you doing susceptibility testing on. Our list at ACL tends to be the same list that we consider contaminants are the same list we would not automatically do susceptibility testing on. So things like coag-negative staph, Cutibacterium acnes, Micrococcus, viridin strep, et cetera. We will end up doing susceptibility testing if we get these organisms isolated out of multiple sets of cultures. So something to consider there. And then how often are you doing susceptibility testing, right? If you get bottles that are going positive over several days. There is this CLSI document, the M47, which is really around blood cultures. And their recommendation is to do repeat susceptibility testing only once every 5 days. You may do it more frequently if you have patients that are positive for Staph aureus or things that may develop resistance more rapidly, like Pseudomonas aeruginosa or inducible AMP-C producers. And then I think the last big topic I have on my agenda before I turn it over to Jorn is susceptibility testing and genotypic versus phenotypic discrepancies, right? So CAP, for those of you that are accredited by the College of American Pathologists, does have a checklist question about using rapid identification methods. And it says that if organism identification and/or antimicrobial susceptibility testing is performed directly from positive blood culture bottles, the broth from the bottle is inoculated onto solid media to assess for consistency with direct results. So you should be doing that. Even you shouldn't be stopping once you get that rapid identification. But what do you do then if you get a discrepancy between your rapid method and your phenotypic method? So I would point you to the CLSI M100. It has an appendix in there, Appendix H, which really goes through a long list of ways to rectify these discrepancies between your rapid methods and your phenotypic methods. I'm not going to go through these all. I'm going to save a few minutes, but the tables are in there. They tell you kind of roughly how to rectify these. For things like MRSA and VRE, they generally tell you to make sure everything looked correct the first time you do it, consider repeat testing, and then err on the side of reporting the resistant, whichever one is resistant, right? For the gram negatives, it's a little bit different. They generally err on the side of reporting the phenotypic results. So whether you have, if your rapid molecular method indicates that it's not an ESBL, but your phenotypic result does indicate that it's an ESBL, you would tend to report your phenotypic result as ESBL positive. You may include a comment on there that says what your potential reason is for seeing that discrepancy. So it's a little bit different for gram negatives. Whoops. Oh, I guess I have a few more. And then lastly, relevant metrics that you want to measure within the laboratory. We already talked about blood culture contamination and how it's an important metric to measure, again, because it can increase cost to patient and hospitals. It can lead to longer stays and more work in the lab. And again, it is for CAP accredited labs, it is an important thing to consider. And CAP has a checklist question about the laboratory monitoring blood culture contamination rates, and that you have an acceptable threshold established. At present, the current national recommendation is 3%. I've seen discussion of it being lowered down to as low as 1%. I think that will be trouble for probably every one of our organizations. I think a lot of us can probably meet that 3% level, but 1% is going to be pretty tricky. So anyway, it's important to have these metrics, to know how to measure them, right? And it's important to share the data back with your hospital, back with your nursing team, all of these folks, right? Determine if there's frequent offenders and whether you need to consider retraining programs and all this kind of stuff, right? And obviously that's a lot of work on the laboratory to maintain that. but it also, in the end, pays off for us if we are working up less contaminated cultures and getting less questions from providers about those types of things. Similar metrics include low volume blood culture draws. So do you measure volume within your laboratory? Do you make a note within your cultures if the volumes look low? You know, how do you let the providers know that this may not be the most effective blood culture? With blood cultures, one of the most important things we can do to get a sensitive blood culture is put the right amount of blood in them. Again, we want to see 10 mils. And again, CAP does have a checklist question about monitoring your blood culture volumes, right? And reporting back to the providers if something doesn't look right. For those of you with maybe the newer, like Beck T-Alert Virtuo systems, it will actually weigh the bottles and tell you right there how much blood is in them. Obviously, that's pretty fancy, and we actually don't use it in our lab, but it does exist. So as you start to look at new instrumentation, that may be something to consider. Some of the other metrics that are important to take a look at are just generally gram stain accuracy. We shoot for greater than 95% gram stain accuracy. And then potentially how often your rapid ID and sensitivity results correlate to your traditional ID and sensitivity results. Just a couple important resources. As I mentioned, the CLSI M47 is a really helpful resource. It's only about 2 years old and talks kind of all principles and procedures for blood culture. And there's a great clinical microbiology review article from 2020 about the practical guidance for clinical microbiologies. And that one's more focused on blood culture contamination, but it just may be helpful for you guys as you kind of work through some of that within your laboratory. So in summary of my part, there's obviously many different ways to perform blood cultures. You guys need to consider what the best practices are for collection, whether you're going to use decentralized models or centralized models. Are you going to use rapid IDs? Seems like most of you do. How are you going to perform your final identifications and susceptibilities? And what metrics and feedback are you kind of measuring and giving back to your providers? So I'm going to skip questions for now and go to Jorn's section on some of the case studies. He's going to be a little more interactive than I was, instead of just spitting data at you. That's okay. You know what you're doing? You know what you need to do?
Hello, everybody. So I'm premising this next section on your participation. So it's not very exciting unless you chime in. So please do that for me. Okay, well, maybe I should. All right. Case number one, we had a newborn with an umbilical cord IV. And it was drawn from a very sick newborn. 1 mil was drawn, and it was not our hospital protocol to do this. However, let's look and see what grew. All right. So what would anybody do with a bacillus in this sort of an odd situation? Anybody have any experience with that? What would you come up with? What would you do if you were looking at this? Anybody?
Anybody? Grandpa's?
So it all depends. If there were more than one blood culture bottle ordered on this, we probably would have called it a contaminant. But if it was the only bottle that they could have gotten, we would have at least identified it.
Okay. All right. Let's see. All right. In my experience, when I've run up against bacillus, it's been like something from the top of the bottle. The bottle hasn't been cleaned, and so change procedure on that. However, you know, when you have a baby dying, you have to grab at all straws. So there are cases of bacillus serious infections. And in this case, the provider did want to treat the baby. So that's what happened there. So would you all say that you would probably report this out as a probable contaminant then? Is that what I'm hearing? No. Okay, Tom, let's hear from you.
Well, we know serious can be serious.
Oh, okay.
And, because this was an unusual situation, I would have had a consult with the physician. And we have we're lucky enough to have a very good pediatric ID doc, and he would undoubtedly have been on the phone. But I wouldn't have discounted it.
Okay. Thank you, Tom. All right. Okay, there's some treatment options. All right. All right, we already got that part done. Let's see here. What's next here? Okay. Okay. All right. Next is the common problem that we have. I just want to hear from everyone in what you would do in what I call the 1 in 4 quandary. So you have one positive blood culture out of 4, let's say 2 sets of like a staph epi. Okay, so what is your protocol when you have this situation of one bottle being positive with staph epi? Anybody want to chime in here? No? Okay.
What?
Okay, Tom's ready. Okay, someone else, okay.
So in our case, we would identify it, no susceptibility, and call it a contam with appropriate commentary.
Okay, yeah, that's what we do too. Anybody else want to chime in? No? Okay. All right, so coagulated negative staph is the most common organism cultured. So sometimes it's related to indwelling catheter. All right, we've already done that. Thank you.
Jorn, just real quick,
Yeah.
does anyone not include some type of comment that says it could be a contaminant in that scenario? I mean, do you just report it as it is, or do you include
We
something?
always say 1 in 4 probable contaminant. We do. I don't know. Heather?
We do not insert a comment as a contaminant. I do, that would be included when I'm doing my contamination rate. I would
Right.
include it then in my
Right.
metrics, but we do not send it out as a possible contaminant.
Okay.
We don't have infectious disease, we don't have specialists like that, and so it's all kind of family medicine type providers, and so we leave it on the discretion of the provider and pharmacy as to treat or not treat.
Right, no. Yeah, we just say 1 in 4 bottles positive with the offending organism, and then say probable contaminants and let it go. If the provider wants something out of it, wants a sensitivity, then they will have to get a hold of us. Okay. Okay, so this is a third case study. We have 4 bottles. We have only 1 coming positive with E. coli. Now that's, like I said, not skin flora organism. And as you know, it's not a skin flora organism usually, though it does cause wound infections sometimes. So what would you do if you had 1 bottle positive with E. coli? Anybody? All right, see what you have to say, Zilka.
Work up with full ID and sense.
Okay, all right, because it's not going to be a skin
No,
organism.
I mean, there's a reason why we draw multiple sets of blood cultures.
Okay.
So, yes, it's a true pathogen. We work it up fully.
Good. Any other comments? No? Okay.
Would anyone not do it that way,
No.
Heather?
All right, Heather. Okay. All right. Okay. Case number 4, we had 3 bottles collected. It was a kind of hard draw. The patient wasn't doing well. One was a pediatric, but they all had 3 organisms in them. So there are multiple organisms in the mix. It's kind of confusing, right? They kind of, well, let's see here what we got. So it's like normal flora, but it's in the blood, right? Normal skin flora, but it's in the blood, and you have more than one organism. What's going on here? Anybody have any clues? Any ideas? Any thoughts? No? Okay.